Next up, we have Eddie Caldow, and Eddie's going to be talking to us about combined rehabilitation for people with cardiovascular disease.
My name's Eddie Caldow. I am a clinical exercise physiologist by trade, which have a background working for the NHS in mostly in cardiovascular rehabilitation. So very much around the sort of use of exercise as medicine, which has already been mentioned before, which is great. So yeah, I'm a lecturer at the university as well. I'm on our nutrition and exercise medicine undergrad degree program and a master's program as well. But I'm currently doing my professional doctorate in the area of combined rehab for patients with peripheral artery disease and coronary artery disease. So bringing people in with lower limb problems, vascular problems, into a more standard recognised cardiac rehab program on there. So hoping to give you a quick overview of this and then some slides on some of the results that we've got on there. So peripheral artery disease, just a quick overview in terms of narrowing of the arteries. Probably more familiar with that, narrowing the arteries in the heart, the coronary arteries that cause things like angina and heart attacks, and mean people end up having to have stents and bypass intervention surgeries and things like that. This is the same process, fairing up of the arteries of the legs. So that causes discomfort and pain on exertion when people are walking, classically, but can also go up to in a small population of people, small amount of people actually needing amputation due to complete lack of blood flow as the process gets worse. So what we're looking at doing with when people are diagnosed with peripheral artery disease is trying to treat them as best we can, and processes like stents and bypass that we're familiar with for heart patients are used for the peripheral artery disease patients as well. It used to be up until 2012, but that was the main treatment option was stents and bypass surgery, maybe some medication as well. But we found that through large amounts of RCTs, meta-analysis, that actually exercise was a really good treatment for someone who is newly diagnosed with peripheral artery disease. It's obviously less invasive of stents and particularly bypass surgery, but actually some of the research was showing that an exercise intervention, which classically means pushing the patient to some pain in their legs to get some what we call claudication pain, symptoms of claudication, actually gets improvements similar to bypass surgery after sort of 12 weeks of exercise on there, and actually better than stents in the sort of long run on there. So it changed very much to looking from those medical interventions, more invasive, to actually getting people to sort of bring on some pain, some claudication pain, because they found that really sort of benefited them. There's a range of different benefits. I won't spend too long on this slide because it's quite busy, but in terms of the vicious cycle that happens with people developing peripheral artery disease and getting pain and discomfort on exertion tends to sort of stimulate them to stop walking, and so they reduce their physical activity. We know reduced physical activity is a problem in all populations of people, but where people are limited with their legs, they tend to sort of start to do less, and that just brings that vicious cycle in. But we know that intervening with that and doing some physical activity and exercise helps to improve collateral circulation to the blood, helps the patient to manage their pain a little bit better and be able to sort of push through that pain when they know that's safe to do to a point, but also sort of right down into from sort of systemic stuff into the sort of cellular level. It's making increased sort of mitochondria, increased ATP availability, and all things like that are going to help this patient with peripheral artery disease. So in terms of a NICE pathway, so the National Institute of Clinical Health and Clinical Excellence, so NICE in the UK, what we're looking at with this is the plan is that with people who are diagnosed with peripheral artery disease, intermittent claudication, the symptoms where I've talked about before, essentially angina of the legs, they're getting that pain or discomfort, we're looking at referring them onto an exercise program. And hopefully what that is going to do is prevent them needing to go on to revascularization. So in terms of some costs, I mean, these are rough costs, but in terms of the NICE pathways, they're looking around about just under £300 for a 12 weeks program of exercise. Imaging, which is then used if people do need to go on for surgeries, around about 100 to 200, but then revascular surgery can be into the thousands, particularly if we're sort of getting complications, which is obviously a lot more invasive on there. So what we're looking at is hopefully trying to sort of stop that in stage 2. That supervised exercise program means that they're not having to go on for further revascularization on there. So despite all this knowledge, despite the nice guidance saying in 2012 that exercise is now first-line treatment for peripheral artery disease, it's still not sort of well provided and well uptaken in the UK. Currently, I mean, there was initial research showing in 2009 it was only around about 30% of vascular surgeons had a rehab centre to refer on to. It's improved a little bit now. Some recent research in 2016 by Harvard tells us saying about 43%. So it's still quite low compared to sort of the cardiac rehab side of things for heart patients. So we do need to get that better. So that sort of came up with this idea of, can we look at a well-established cardiac rehab setup that provides over, I think it's around about 250 hospital-based or community-based programs for initial treatment of people diagnosed with heart problems. Can we use that setup, that infrastructure, and start to bring patients in? There has been some research done with heart failure patients and pulmonary patients who have similar limitations in terms of shortness of breath and fatigue. So we looked at that and thought, okay, could we use peripheral artery disease, so we could combine peripheral artery disease and coronary artery disease on there. However, although these patients do have the same disease process of atherosclerosis, and fair enough, the way it presents is very different. You know, chest pain versus leg pain. Chest pain when we stop, leg pain when we push through. And we'll see in some of the slides coming up that the activity levels of peripheral artery disease patients where it affects the legs are very much different to coronary artery disease patients. Also as well, we need to think about, you know, we'll get their heads around and know what the illness perception is that might differ between these two populations on there. So that's sort of looked at. So a quick overview of what the study, which has completed all of its data collection, thankfully, so onto the fun bit of analysing and writing up now. But we're looking at conducting this pilot study with a feasibility bit in there, which I'll look at to see whether is it feasible, and then if we can get some pilot data to then use to power further studies and look on to sort of getting some larger scale studies from this work on here. So essentially, the patients are referred in with peripheral artery disease into either a standalone peripheral artery disease program, a control group where it's PAD patients only, versus a combined group where they're exercising at a different hospital working with alongside heart patients as well. So there's 2 centres, 2 large hospitals that are involved with this. And essentially from initial assessment, they get enrolled onto the program, which is 12 weeks, once a week, with some home-based exercise programs to look at as well. And then we monitor them again at the end to see what's changed on there. Monitoring through things like walking capacity on a treadmill walking test, but also as well Actipal accelerometer data as well to see what's going on in the first week before they start, and then after their 12-week program on there. So in terms of feasibility stuff, it was really well in terms of recruiting patients was relatively easy to do. We got a good number. There was a lot of patients that we couldn't enroll purely from a time point of view, as I was doing this myself around a full-time job. So a lot of patients were missed just because I couldn't assess them in time. We got loads of patients through, and they were retention rate was, considering the retention rate is around about 50% for cardiac rehab. We had some really good retention rates on there. I'm only going to show you this quick one of the control group one, but these are some of the measures we looked at: some quality of life questionnaires, some perceived walking questionnaires, and the accelerometers, the Actipals we used. Essentially, there's the summary from this slide, and it was the same with the peripheral artery disease group and the heart group. They were all well received in terms of the questionnaires and in terms of the activity monitors wearing them, getting them back, and filling out the diaries as well. It was really good uptake on there. In terms of the accelerometers, we got really good feedback on. Most patients actually forgot they were wearing them once they were put on, until one of them, as you can see bottom left there, actually, you know, middle of the night going to the toilet and it starts, they notice it's flashing. So it was literally, that was the only time when people really noticed on there. So not very invasive at all. And initial sort of slides are showing there's really good uptake on there, but and the combined programs are great. But just for time, I'm just going to make sure I can go through some more results in terms of the activity. We found that the programs, they really did improve their initial onset of claudication pain and maximal walking in the PAD groups, which is similar to other research. Well, then we found as well that walking impairment with the peripheral artery disease groups improved as well. But then looking at the more accelerometer data on there, we did find walking capacity, so this is treadmill test data on there, did improve, but the daily walks did improve on there. What we can see on here, just as interesting to point out, is that the heart group on the right start and finish with a higher average daily steps, which is quite interesting for this group. We know their difference on there. I'm not going to go too much in this. Abelandy is coming up. We'll go through probably this sort of data for her study a lot more. But again, this is showing that the two populations are really different in terms of when they start and finish, in terms of the time spent walking. For the PAD groups, walking for prolonged time is very, very different. It's very, very much reduced from the cardiac patients, both at the start and at the end on there. So just to summarise on there, so the study to see whether we can combine, there's still more data to sort of analyse and sort of look at, but hopefully this data is going to show us what these patients are like walking, start and finish, but also then use that data to go for a bigger study to try and see what the exact sort of effectiveness is and whether it's a viable option for the NHS. So a whistle stop to all my research. I'll leave it there and sort of take any questions now.
That's great. Thank you very much indeed, Eddie. That was really, really interesting. I'm just wondering, so that the scale of this, you mentioned that I think you said less than 50% of surgeons can refer to exercise rehab at the moment, but presumably just about everybody qualifies for this as a primary intervention now on the guidelines. So there's a very big gap there which needs to be filled.
Exactly, yeah, exactly. And I think a lot of the sort of initial research has shown that because they also looked at what were the barriers, and a lot of it was logistics of it, getting the cardiac rehab does exist and there's lots of centres, but for peripheral artery disease rehab, it's where do you refer them in terms of a lot of places in the NHS can't just start up a new programme. So there has been one running at Manchester Way, which I'm working with for like 15 years, but it's exceptionally rare. So it's the money side of things. It's setting up, it's getting the equipment, it's getting the rooms, and it's getting the trained staff. So that's why we sort of thought, what about cardiac rehab? They already have the rooms, they have the trained staff. It's a very similar process. The exercise is slightly different, but can we bring them in? So yeah, it's pretty poor provision considering NICE have said that it has to be first line treatment. So unfortunately, a lot of patients do get their intervention is a leaflet and sent home and go and walk yourself, which can be done, but it's not easy.
And is there evidence that if this is the first line intervention, that the whole vascular surgery, that more extreme as it were interventions, can be avoided completely?
Yeah, I mean, we did when I started off, when I was still working in the NHS, we did a little sort of small sort of pilot of see where we can get some of these patients in, and we found, I think it was around 90 patients that we looked at, and I think it was off the top of my head around about 85% of those patients did not go on for vascular consult, so not even going for the surgeon, but they felt that they didn't need to go back to see the surgeon to investigate further, and that was the patient's own choice. They felt their leg symptoms had improved enough that they didn't need to. So, that's even just before even consulting on do they need surgery or not. So it was a big reduction, and we're hoping that with this bigger study and further studies, we can kind of really nail that down. That intervention, activity, and education can limit that need to go on for more costly, but more invasive and more complicated surgery for patients to have to go through. Really.
So I mean, the potential's there to reorganise costs and really save money and prevent a lot of unnecessary surgery potentially. Exactly,
and even I mean, some patients I've spoken to are saying that they still have that idea, oh, why can't I just get the surgery? But a lot of the research is showing that you get a stent or bypass in your legs, and you end up a few years later going back again, because the exercise is something, and the education is about changing other lifestyle factors as well as the preventing it from getting worse, where a stent or a bypass can be like a little elastoplast going on for a little bit, but then the problem can come back in a few years. And I definitely saw that with a lot of patients who I couldn't take on for my study because they'd already had leg interventions, bypass, but they were coming through the system again years later, 2-3 years later, because another artery had flared up or the bypass had flared up, because you're not getting that with the surgery, but you are getting that intervention with the exercise and education as well. So there is massive potential costs to the NHS and invasive procedures to the patient. So hopefully this will help impact that.
And just my last question, how do the clinicians who are delivering the service, how do they feel about it? How does it affect their clinic that they're running?
Yeah, I think it's a really good question. That's something that we're looking at. You know, we've got anecdotal stuff on it from working with them and chatting to them, but to see if there's something that we can get a bit more on paper. But a lot of the times, absolutely fine. The patients find it great, but the staff find it relatively easy to do, to bring them in. Obviously, it's more patients coming through the service, but one interesting bit is, you know, we're cardiac rehabs where I've worked for years. It's, you have different patients coming through, but they've all got similar conditions and interventions. Whereas if you bring in a new group of peripheral arteries, it brings a little bit more of a difference into the workplace as well. You get more variety that challenges you as a clinician as well. So there's a lot sort of that interest and that sort of side of things from clinicians as well. So straightforward and hopefully quite interesting. But again, if we can get more, you know, hard and fast data on that, I think that's the next step of this study as well.
That's great. Thank you very much indeed, Eddie. That's great stuff. Thank you.